Good morning. Welcome to the Department of Medicine Ground Rounds. We have a guest today who's going to talk to us about an important problem related to cardiology and oncology and blends the two. And I'll have Dr. Boley introduce her in a second, but a few comments first. A couple of weeks ago, I heard that Stan Musial had died at age 92. Some of you may not know Stan Musial. I remember him well, not him, but of him, because he was my father's favorite baseball player. And he was a Cardinals fan, and when I was training in St. Louis, my father would come and visit, but they would love to go downtown with me to a baseball game so that he could spend some time in front of the statue to pay homage to Stan Musial. But on this day, we remember another baseball player. Jackie Robinson was born on this day back in 1919, the first black player in the major leagues, and he started with the Brooklyn Dodgers in 1947. Run about 10 years later, and in 1957, was the first time that someone inserted an external artificial heart pacemaker with an internal electrode sewed into the heart muscle. So it was connected all the way to a desktop pulse generator. Now, of course, this became bulky and things have changed a lot, but that was an important investment. It was a team led by Dr. Walton Lillihei from the University of Minnesota. Between those 10 years, right in the middle of those 10 years in 1953, was the creation of circulation research. And circulation research has become the most important and prestigious basic and translational research journal in cardiology in the world. First editor was Dr. Carl Wiggins, and it has about 20,000 in circulation, and its impact factor is close to 12 now, I'm told. And the previous two sites of the editors was Harvard, Hopkins, and little did we know then in 2009 that Louisville will become the home of this prestigious journal, thanks to Dr. Roberto Boley. So in 2009, our own chief of cardiology, Dr. Roberto Boley, becomes the editor-in-chief of the most important research cardiology journal in the world. And that is even more important today because I'm told this week, Roberto, that you have been just elected again by the American Heart Association to continue to be its editor for another 5 years. And that's a tremendous honor to your credit, to your faculty, to this department, and to this organization. And in celebration of circulation research in cardiology, we have our guest speaker who's going to talk about some cardiac issue today. So, Dr. Boley, please introduce our guest.
Thanks, Jesse. I appreciate your comments. So it's my pleasure today to introduce another addition to our family, which has been growing quite rapidly in the last 2 or 3 years, Dr. Carrie Geisberg Lenneman, who joined us last August. Carrie received her MD degree from Medical University of South Carolina in 2003, and then moved to Nashville, where she completed a residency in internal medicine and then a cardiology fellowship. Following the fellowship, she was appointed instructor of medicine and then for 2 years assistant professor of medicine. And during that time, she was selected as a member of the course in Masters of Science and Clinical Investigation, which she received in 2010, as a manifestation of her interest in clinical and translational research. Her major interest is this field of cardio-oncology, which is a new area that is developing in both oncology and cardiology. Essentially, its interest, it focuses on the pathogenesis and treatment of the cardiac complications of cancers, particularly chemotherapy. She has spearheaded a number of studies. She's the principal investigator for the PACE in breast cancer study, which is concerned with predicting adverse cardiac events in breast cancer. And she's submitting a number of applications for additional studies in other oncologic disorders. She has received a fellowship from the Heart Failure Society of America in 2012, which supports 80% of her salary plus travel and equipment expenses to study heart failure. She's already published 9 papers in this field. So she's clearly an outstanding, very promising clinician scientist. She is totally motivated and committed to academia, and we are delighted to have her in our family again. Thank you, Carrie.
Well, great. Thank you for inviting me to come share some information with you guys this morning. Like Dr. Bowley was saying, I'm in oncology today, specifically this evolving collaborative field. Unfortunately, I have no relevant financial disclosures, but if you have any good stock tips, my ears are all open. I will ask for a little bit of audience participation, and I'm a co-investigator in a phase 1 study of GTF2, but we'll not really talk about that today. So, pop culture quiz. Anyone know who this is? Right. Anyone know who this is? Shirley Temple, right? How about this one? Melissa Etheridge, right? How about this? Christina Applegate, exactly. This may be a little tougher. Anyone know who this is? This is Rose Murphy. So this is Rose Murphy. She's the mother of Teddy Bridgewater, our now famous quarterback for U of L. Anyone know what these women all have in common? Breast cancer, of course. Well, so Sandra Day O'Connor, obviously the first female Supreme Court judge, returned to the bench 1 week status post-mastectomy. Shirley Temple was diagnosed with breast cancer in 1972, and in a public interview was the first person to ever say the words breast cancer, very much taboo to even use the word breast or cancer. Melissa Etheridge was diagnosed in 2004 and was proudly sort of embraced the fact that she was undergoing breast cancer chemotherapy when she performed in the Grammy Awards. And then Christina Applegate was diagnosed with very early stage breast cancer and has been a huge public advocate for early detection of breast cancer. And as I mentioned, Rose Murphy is our celebrity mom, who is where Teddy Bridgewater says he draws his inspiration from, actually. He says his mother never missed a single home game when she was undergoing breast cancer chemotherapy. So, 1 in 8 women will develop breast cancer. There are greater than 2 new cases per year. About a third of these cases are actually the HER2 positive breast cancer, and the cardiac effects are as frequent as 20%. So as you can see, looking at statistics, 1 in 5 women could potentially have a cardiac effect of their chemotherapy. And so look at up here, there are 5 women. So potentially one out of 5 women up here could have had a cardiac effect. And really, the long-term cardiac effects are really not fully known. So our outline for today's talk, I thought we'd discuss the role of cardio-oncology and review current AHA and ACC guidelines. We'll talk about what is cardiotoxicity and review various clinical cases. We'll review the prognosis of chemotherapy-induced heart failure, describe current cardioprotective strategies and appropriate monitoring, and review guidelines for cardiac monitoring in cancer survivors. So I get asked a lot, what is cardio-oncology and why is it important? Well, as you can see, it's estimated by 2020 there'll be 18 million cancer survivors. So this is the largest growing population of individuals who are accessing the healthcare system. And during the past 5 years, there have been greater than 30 new targeted agents that have emerged, and we really do not know the long-term consequences of these targeted agents. The purpose of cardio-oncology approach using these life-saving chemotherapies and to minimize any interruptions to the chemotherapy regimen. Our goal is to enhance cardiovascular monitoring, to minimize any cardiovascular complications, and overall improve the outcomes in these cancer survivors. So let's talk about a case. We have Ms. Jackson. She's a 38-year-old premenopausal woman with triple-negative left-sided breast cancer. She underwent a radical mastectomy and an axillary lymph node dissection and had 4 to 10 positive lymph nodes. Her oncologist plans to give her anthracycline and cyclophosphamide for 4 cycles, followed by Taxol with subsequent radiation. She has no history of hypertension or diabetes. She walks on weekends and says she gets a little bit winded after walking. She's a busy mom with 2 children. But she does have a history of gestational diabetes. She's over 29 and has a family history of heart failure. So what is Ms. Jackson's stage of heart failure according to the ACC and AHA 2009 focused updates? Is she stage A, stage B, New York Heart Association Class 2 because she's a little winded after walking. She's stage pre-A, or you can't classify her heart failure stage because she actually doesn't have heart failure. Any guesses? So she's actually stage A. So it's sort of an important point here. So the writing committee in 2009 came up with a new way to sort of classify heart failure by the various stages. And the majority of our previous guidelines had focused on treatment of stage C, which is structural heart disease with prior structural heart disease and symptoms of heart failure, or stage D, which is refractory heart failure requiring specialized interventions. But the writing committee realized that it's really important to sort of emphasize how can we identify sort of this at-risk population, those that are at risk for heart failure, and that includes these stage A patients that have various risk factors, including hypertension, underlying atherosclerotic disease, diabetes, obesity, or metabolic syndrome. And specifically, they identified this group of individuals receiving cardiotoxic medications or having a family history of heart failure. So these are actually technically stage A patients. And obviously, we want to prevent progression to even stage B, which is evidence of structural heart disease, but without actual symptoms of heart failure. And since we're in horse country, the whole purpose is to catch the horse before the horse is out of the barn. And so the goal with identifying these stage A patients is to apply appropriate therapeutic goals. And it's to treat hypertension according to the JNC7 guidelines. It's to encourage smoking cessation and limiting alcohol consumption. It's encouraging exercise, appropriate diet, and controlling all the metabolic syndrome. And in certain individuals, obviously, if you have underlying vascular disease, start them on ACE inhibitors and ARBs when appropriate. So how accurate are we as clinicians in reporting symptoms during chemotherapy? Well, this is a study done in prostate cancer where you can see 38% of the time physicians miss the symptoms of fatigue, and 77% of the time we miss the symptoms of dyspnea, which are two of the most common symptoms that can overlap between cancer treatment and heart failure. So you can see we cannot just rely on our histories themselves. So we actually need better ways to sort of define and monitor cardiotoxicity. So what is cardiotoxicity? This is probably the biggest room for improvement in cardio-oncology. There's not one single uniform definition of cardiotoxicity in this evolving field of cardio-oncology. And you can see there are various classifications of cardiotoxicity. If you look at the ACC and AHA, we have different ways of classifying stages of cardiotoxicity. If you look at the cardiac review evaluation criteria, which is what is used for clinical trials, they have different definitions, as well as the NCI common terminology of adverse events. So this is actually probably the biggest room for improvement in our field, is to actually come up with a uniform definition. And as you can see here, some of the largest clinical trials in breast cancer all had different terms and definitions of cardiotoxicity. So how should we actually look at cardiotoxicity? Well, I think as this field is evolving, many of us feel that we should, for periods of monitoring, screening, and trying to prevent early development of cardiotoxicity, we should have sort of a broad and inclusive definition that can include arrhythmias, abnormal troponin values, the development of diastolic dysfunction, development of left ventricular hypertrophy, or even a sort of subclinical drop in ejection fraction. But obviously, when we're looking at when we might need to stop a clinical trial or alter the regimen, we might need to have a more concise and defined definition, such as strict criteria for a drop in the ejection fraction and hard endpoints such as MI and stroke. So unfortunately, I don't have any wise words to leave you with to tell you exactly what cardiotoxicity is, but I think the NCI and the NHLBI are working to put together a committee, so we will have concise definitions coming soon. So let's go back to our case. We have Ms. Jackson. Like I said, she has a history of family history of heart failure. She did have some gestational diabetes. She is overweight, and she's referred for pre-chemo consultation for monitoring strategy. And let's review what chemos she's going to actually receive. She's going to receive anthracycline, which have been known to potentially cause cardiac myocyte damage and heart failure. She's going to be receiving an alkylating agent, cyclophosphamide, which does put her at higher risk of thromboembolic disease. And she's going to be receiving a microtubule inhibitor, which puts her at a little higher risk of having a rhythm disturbance. So we know anthracyclines have been used for greater than 50 years, and they're important for the treatment of breast cancer, sarcomas, lymphomas, and leukemias. And they've been very effective in producing a very good clinical response. But we always have to sort of counterbalance that in a way that the potential concern of developing cardiac injury or heart failure. So what is the potential cardiotoxicity? You can have acute or subacute toxicity, which can range from arrhythmias such as AFib or even SVT. You can have pericarditis, myocarditis, or acute heart failure, which can occur in up to 10 to 20% of individuals, specifically in an elderly population treated with CHOP therapy. You can have chronic or late toxicity, which can occur anywhere from 1 year up to 20 years from your exposure. It's higher in those that have had childhood malignancy, and it can occur in up to roughly 5% of individuals. So let's talk about the mechanisms of anthracycline-induced cardiotoxicity, because if we knew the mechanisms, then we could target and prevent any cardiac damage. Unfortunately, the mechanism is multifactorial. It's a busy slide, but we'll sort of walk through it. Anthracyclines are known to cause intercalation into DNA, which inhibits cell proliferation and replication. It causes release of reactive oxygen species, which causes mitochondrial disruption, as well as lipid membrane peroxidation. It interferes with the calcium handling within the cardiac myocytes and can alter adrenergic function. It can interfere with the calpain-dependent proteolytic cleavage of titin, which titin is one of the largest sarcomeric proteins in the cardiac myocyte and is important for the passive restorative forces of the sarcomere, as well as it is thought to actually decrease circulating progenitor cells, which are important for cardiovascular repair. And when you look at H&E stains of myocardium that's been exposed to anthracycline, you can see there's a significant amount of sort of myocyte disarray, an increased number of vacuoles, and significant distortion of the mitochondria. So you can see it's directly cardiotoxic to the myocardium. So how can we, what are the risk factors for cardiotoxicity? We've known from a number of studies that the biggest risk factor for cardiotoxicity is that your lifetime cumulative dose puts you at risk for cardiotoxicity. And as you increase your lifetime dose, your probability of developing heart failure goes up drastically. And therefore, many people try to keep the lifetime cumulative dose well below 450 milligrams per liter squared. So what are the other risk factors for anthracycline-induced heart failure? Well, unfortunately, being a female puts you at higher risk. Having ages at two extremes, being exposed when you're a child or later in life. Increased conform exposure, concurrent radiation therapy, or also concurrent administration of any other chemotherapy puts you at risk. And also having an underlying history of heart disease, whether it's an MI, heart failure, hypertension, diabetes, and even aortic stenosis puts you at higher risk. However, despite knowing all these potential risk factors with anthracycline, we're still doing a poor job at predicting which individuals will develop cardiotoxicity. And I think a lot of this has to do with the intervariability of the metabolism of the pharmacology of doxorubicin. When you think about the pharmacology of doxorubicin, it's really dependent on the drug's transport proteins, such as the influx and the efflux proteins, such as the multi-drug resistant proteins, and the enzymes that help control the reduction of doxorubicin to doxorubinol, the alcohol moiety. And so I think as we go forward and we know more about genetics, we'll be able to hopefully add some more information to someone's risk of developing cardiotoxicity. There was a small case-controlled study that actually looked at this, and they found out those that had a mutation in the carbonyl reductase inhibitor 3 had increased risk of anthracycline-induced cardiomyopathy. So like I said, as we go forward and we know more about our genetic profile, we'll hopefully be able to improve our risk assessment of these individuals. So how do we currently look at reducing the risk of anthracycline cardiotoxicity? Currently, we look to decrease the total cumulative dose. We look at structural modifications if someone is higher risk. The oncologist may choose to use epirubicin over doxorubicin. We can look at using liposomal preparations such as Doxil. However, the big trade-off with this is it's very expensive and there have been national shortages. We can use iron chelators, dextroxane. However, again, there's some trade-offs with this. There's increased myelosuppression, and there's concern that it could potentially decrease the anti-tumor capacity. We've looked at various antioxidants, vitamin E, vitamin C, and unfortunately they've not really borne out as positive results in clinical trials. And we've looked at changing infusion protocols. Instead of having like a shorter infusion, spreading it out over a 24-hour period, and still infusion protocols have not consistently led to decrease in cardiotoxicity. So how are we going to look at getting sort of a better risk assessment of a person's individual cardiotoxicity? That's one of the reasons we started this PACE study, Predicting Adverse Cardiac Events in Breast Cancer. It's a longitudinal prospective study in breast cancer patients where we're enrolling women who are going to receive either anthracycline or a HER2 antagonist and following them for 5 years for cardiac outcomes. The primary outcome is the development of either subclinical or clinical cardiac dysfunction. And at the end of the study, we're going to incorporate in a statistical model various cardiac risk factors, lifestyle risk factors, genetic data, biomarker panels, baseline cardiac performance, and integrate this. So hopefully we can then enlighten the patient as well as the oncologist to give a better cardiotoxicity risk assessment profile, and then sort of stratify people as either high, moderate, or low risk. And so our interim analysis of our PACE study, this was done in October of this year. And we had 78 patients with a median age of 50. We looked at just the cardiac risk factors in our breast cancer patients. Granted, this is Tennessee, because this was mostly done for my Vanderbilt study. You can see there's no shortage of cardiac risk factors. 58 were hypertensive, 68% were either overweight or obese, and 63% were actually inactive by self-reported questionnaire. So this group of women with breast cancer have a number of cardiac risk factors that we need to sort of monitor. To date, we have 99 women enrolled so far. So we're increasing and hoping to enroll to actually open the PACE study here at Louisville in the next few months. So looking at the maximal change in ejection fraction from our PACE study, within the first 6 months of chemotherapy, from our 70 patients that actually had paired echo data, 15 had a drop in EF greater than 10 units. So roughly it comes out to be 21%. So if you think about our stage A of heart failure patients, 1 in 5 women from our PACE study progressed from stage A to stage B within the first 6 months of a chemotherapy treatment. So just showing you that we really need to sort of be aware and monitoring these individuals. And this led us to say, why are we seeing such a high prevalence of people that are transitioning from stage A to stage B heart failure? Does obesity play a role in anthracycline cardiotoxicity? And as I mentioned before, in our population in our PACE study, 68% of the cohort was either overweight or obese, which is a little higher than national averages. So we started wondering, is inflammation in the setting of obesity playing a role in leading to this higher than average incidence of cardiotoxicity? And what we've been looking at in our PACE study is when you sort of break down the groups by normal BMI or a BMI greater than 25, is there an exaggerated inflammatory response? And so we looked at CRP levels as well as PI1 levels, which are pretty good markers of inflammation. And we looked at these markers of inflammation after chemotherapy. And you can see in the group that had a BMI over 25, they have a much higher exaggerated incidence of inflammation. And so this question is, would statins actually help decrease this anthracycline cardiotoxicity, and especially even be more beneficial in our obese or overweight patients for this fact? This is actually what we're submitting for our AHA and for our Mary Kay grant to sort of study this in more detail. So let's switch gears. Let's talk about Ms. Smith. She's a 58-year-old female with a history of breast cancer. She comes to you to see you in your clinic for new onset heart failure due to anthracycline exposure. And she received roughly 240 milligrams per meter squared during her anthracycline treatment. This is about 5 years ago. Her echo shows she has an EF of 35% with global hypokinesis. And she asked you about her 10-year prognosis with heart failure, now that she has anthracycline-induced cardiomyopathy. And true or false, Ms. Smith's prognosis is better than in patients with ischemic heart failure? 50-50 shot. It's actually false. So when you look, Michael Felker looked at this study a few years ago and took 1,200 patients with various forms of cardiomyopathy and stratified them by etiology and looked at pericardium, idiopathic, ischemic, anthracycline-induced cardiomyopathy, infiltrative, and HIV. And actually found that those that had doxorubicin or anthracycline-induced cardiomyopathy, that only 50% were still surviving at 2.5 years after their diagnosis. So in general, their prognosis is actually very poor. And if you look at the hazard ratio in comparison to idiopathic, their hazard ratio is 3.5 times higher. So in general, these individuals that go on to develop heart failure have a poor prognosis. So this led us to ask the question, what is the trend in individuals that develop end-stage heart failure from anthracycline-induced cardiomyopathy and then go on to end up needing a orthotopic heart transplant? And so we looked at the UNOS database, which is the United Network of Organ Sharing, where they keep really close records of all the heart transplants. And we can see over the last 24 years, there's been an increasing trend in the number of heart transplants that are occurring for doxorubicin-induced cardiomyopathy. So you can see, despite us using anthracyclines and having appropriate treatments for heart failure, we're still having a sort of an increasing trend in this number of people that have anthracycline-induced cardiomyopathy requiring cardiac transplant. The good thing is that we did look at heart transplant survival in these individuals that have anthracycline-induced cardiomyopathy. And when you looked at a adjusted statistical model, that in general, their overall 10-year outcome is slightly better than those of all other forms of cardiomyopathy. So the good thing is that if these individuals go on to develop end-stage heart failure and need a transplant, once they're transplanted, their life expectancy is as good, if not slightly better, than all comers. Oliveira and others actually, too, wanted to see was there any difference in outcomes in individuals that had anthracycline-induced cardiomyopathy that then had to go on and receive some kind of mechanical circulatory support with either an LVAD or an RVAD. And they looked at these outcomes comparing anthracycline-induced cardiomyopathy in comparison to non-ischemic and ischemic. And when you looked at their outcomes up to 36 months of receiving a mechanical circulatory support, there was no statistically significant difference between these individuals. Again, showing that these individuals, if they go on to develop end-stage disease and they need mechanical circulatory support, their outcomes are just as good. The interesting thing that Oliveira and others found is that there was an increase in the number of individuals that needed RVAD support. So something to definitely be teased out a little more. All right, let's keep going. Tell me the case. Now we have Mrs. Jones. She's a 64-year-old female that had stage 2 HER2-positive breast cancer. She underwent a mastectomy with adjuvant chemotherapy, including Taxol, carboplatin, and Herceptin, otherwise known as trastuzumab. She had completed that for an entire year in 2009. And now is presenting 3 years later with asymptomatic systolic heart failure with an EF of 45%. And she asked you, is trastuzumab associated with the development of cardiac dysfunction? And yes, it can be associated with some cardiac dysfunction, so let's talk about that a little more. So trastuzumab was FDA approved in 1998. To remind everyone, it is a monoclonal antibody to the overexpression of the HER2 receptors. This made sort of a great impact in our therapies for HER2-positive breast cancer because we saw a 20% risk reduction in these HER2-positive breast cancer patients. However, we gained more insight into the cardiotoxicity with the use of trastuzumab. We saw a 4-fold increase in cardiotoxicity when we had concurrent administration of trastuzumab with anthracycline. And so that led people to question, why is a HER2, or otherwise known as a ERK2 antagonist, so cardiotoxic? And so the question is, does the heart actually express HER2 receptors, and does the heart actually take up trastuzumab? Well, this is 20 metastatic HER2-positive breast cancer patients where they gave them radio-labeled trastuzumab and did a single photon emission CT. It's the sagittal section of a CT of these individuals. And you can see here from the sagittal section a nice sort of silhouette of the heart. So the heart does express HER2 receptors in the heart. This is a hot liver. So this is a metastatic patient. But as you can see, the heart does take up trastuzumab. So how does trastuzumab affect the heart? Well, our endothelial cells express various forms of growth factors, and this cartoon, I'm showing it expressing neuregulin. During any period of stress, ischemia, exercise, or cardiac exposure, neuregulin is proteolytically cleaved from endothelial cells and will act in a paracrine fashion on the HER receptors. In this case, I'm showing it activating the HER2 dimerizing with the HER4 receptor. And this causes sort of the downstream signaling that's important within the myocyte to help the myocyte grow and maintain normal function and help the myocyte survive. And you can see if you have trastuzumab, which is the monoclonal antibody, blocking some of these HER receptors interacting with neuregulin, that you could then be impairing the important downstream signaling for growth and maintenance within the cardiac myocyte. And this is exactly what people were seeing when they saw conditional knockout mouse. When you block the neuregulin and HER2 signaling, that you developed a thin and dilated left ventricle, very much the same phenotype that we were seeing with trastuzumab-induced cardiomyopathy. And this just sort of drives home the point that neuregulin/HER2 signaling is critical for maintaining normal heart function. So what else were we seeing clinically? Well, Michael, you and others took 38 breast cancer individuals who received trastuzumab and went on to develop some form of systolic dysfunction, and then initiated them on standard heart failure therapy. And luckily, when he initiated these individuals on standard heart failure therapies, the majority of people had recovery in their systolic dysfunction. And the interesting thing was that when they actually re-challenged them with trastuzumab, that their cardiac function maintained. So it was sort of important information that if you started these individuals on standard therapy, that they usually could finish their completion of trastuzumab. So what do we know about the use of trastuzumab and the incidence of heart failure, especially in elderly individuals? This study was recently published from the SEER registry that looked at the trastuzumab use since 2000 for women who were aged 67 to 94 years old. And from the study, they saw the use of trastuzumab has increased by 8-fold from 2000 to 2007, as you can see here. Then they wanted to look at the incidence of heart failure, so they calculated the adjusted 3-year incidence of heart failure for those patients receiving trastuzumab, and they actually saw that in the trastuzumab-treated group, there were 32.1 more heart failure cardiomyopathy events per 100 patients. In comparison to those individuals that had no adjuvant therapy, there were 18.1 heart failure/cardiomyopathy events per 100 patients. And obviously, when they added trastuzumab with anthracycline, there was an increase in number of heart failure cardiomyopathy events over the 3 years at 22, 33, and 41, respectively. So what do we know about trastuzumab? It's very effective in the treatment of HER2-positive breast cancer. It should not be concurrently administered with anthracycline. The majority of the LV dysfunction is reversible, but we do know from longer-term studies up to 30% will progress to an LVF of less than 50%. And the use of trastuzumab is increasing, and heart failure/cardiomyopathy events are common, especially in these elderly breast cancer survivors. So let's go to another case. Now we have Mrs. Smith. So she's returning back to you and unfortunately says her sister has been diagnosed with, newly diagnosed with breast cancer. Is going to be starting chemotherapy, and she wants to know, are there ways that we can prevent anthracycline-induced cardiomyopathy for her sister? Can we improve cardiac monitoring? So you start sharing with her some of the small studies that have been done, looking at various cardioprotective strategies. And this was a study looking at use of beta blockers prior to anthracycline exposure. And it was a study of 50 individuals in Turkey where they were randomized to 12.5 milligrams of Coreg at baseline and then had an assessment of cardiac function 6 months later. And then you can see from the carvedilol group, there was a more stable cardiac function at 6 months in comparison to the control group, leading some people to think that carvedilol may have some cardioprotective benefit in people treated with anthracycline. There are some criticisms of the study, not only the small size, but the QD dosing of Coreg is a little bit odd because it's not exactly pharmacologic. And there were some small discrepancies of chemotherapy dosing. But I think there's still room to study this more for sure. There's some other interesting data about beta blockers. This was a epidemiologic study that looked at baseline hypertensive breast cancer patients and wanted to see what the time to event until they develop metastatic disease, as well as their overall 10-year survival. And individuals on beta blockers had longer times until they developed metastatic disease, as well as had increased 10-year survival. So there's some epidemiologic data. There may even be some benefits of being on a beta blocker from the oncology outcome standpoint. And sort of the possible mechanism behind this is that beta blockers obviously work on the sympathetic nervous system by decreasing the release of norepinephrine. And norepinephrine is thought to activate macrophages that then crosstalk with the metastatic cancer cells. And when activated by epinephrine, it is thought to lead to metastatic spread of these cancer cells, so that if you give a beta blocker, you're potentially decreasing that crosstalk. So let's talk about other therapies that have been looked at, sort of decreasing cardiotoxicity. This was a randomized placebo-controlled trial of valsartan for the prevention of cardiotoxicity with CHOP. This was 40 lymphoma patients in Japan. They were randomized to either valsartan 40 milligrams or placebo. And they looked at BNP values within the first 7 days of CHOP therapy, as well as diastolic dimension and diastolic volumes. And they saw that the valsartan group had lower levels of BNP and had more stable end diastolic volumes at 7 days. They did not see any statistically significant change in ejection fraction, but you wouldn't necessarily expect to see that within the first 7 days of CHOP therapy. Then another study, small study from Turkey, looked at 40 individuals where they randomized them to 40 milligrams of atorvastatin prospectively prior to their anthracycline exposure. And you can see in the statin-treated group, there was more stable cardiac function. The mean change was only 1.3, versus in the control group, they had a 7.9 point drop in their LV function. So again, suggesting that maybe even statins have a potentially cardioprotective benefit. There was another recent study from the Cleveland Clinic where they retrospectively reviewed their electronic medical record and identified women diagnosed with breast cancer that were treated with anthracycline, and they did sort of a propensity score matching. And then they had, in the statin group, had 67 patients, and the other group had 134, and they had follow-up at 2.5 years. And they saw that the incidence of heart failure in the statin treatment group was lower than the other propensity score matching group. The only other sort of interesting factor is that this group that was on statins tended to have a higher percentage of concurrent use of beta blockers and ACE inhibitors. So it's hard to clearly say that this is all statin effect because we had a fair number of individuals on beta blockers and ACE inhibitors. It was interesting, these authors did conclude that breast cancer patients with interrupted statin therapy had a lower incidence of anthracycline-related heart failure, but they also found additional predictors for incident heart failure risk were any individual that had a cardiac risk factor at the time of cancer diagnosis, that increased their hazard ratio of 5 of having an episode of incident heart failure. They also found out if you had a baseline EF of 55%, that increased your risk as well as use of trastuzumab. So again, there's adding up more data, epidemiologic data, that statin use can be beneficial. This was a group looking at our population in Denmark, and they had this hypothesis that reduction in cholesterol may limit cancer cell proliferation, growth, and metastasis. And so they retrospectively reviewed all the patients enrolled in the Denmark population from 1995 to 2007 and looked at cancer-related mortality. And they had about a little over 18,000 patients that were on statin therapy versus 277,000 patients that were not on statin therapy. And they saw that actually those that were on statin therapy had a decreased incidence in death from cancer, as well as a 15% reduction in all-cause mortality. Obviously, the limitations of the study is that it's retrospectively and it's predominantly a Caucasian population. But I hopefully I'm sort of creating this whole idea that there may be benefits of statin use. So is there a way we can predict cardiotoxicity in patients? And there's a large cardio-oncology group in Milan, Italy, that have been looking at the prognostic potential of troponin and sort of identifying patients at risk of developing cardiac events. And so Daniel Cardinelli and others took 703 patients that were receiving high-dose chemotherapy and looked at troponin I levels. They had an early troponin, which was during the high-dose chemotherapy, and also checked late troponins, which were usually roughly 1 month from their high-dose chemotherapy. And saw three patterns sort of emerged. You had troponin positive people that remained positive. You had troponin positive group that then became negative. And then you had some individuals that were troponin negative that stayed negative. And they looked at cumulative cardiac events at 3.5 years. And these sort of composite endpoints were sudden death, cardiac death, acute pulmonary edema, heart failure, asymptomatic decline in LVEF of 25%, life-threatening arrhythmias, conduction disturbances requiring pacemaker. And you can see here, troponins did seem to be somewhat prognostic for having a cardiac event up to 3.5 years. The persistently positive troponin group had an 84% chance of having some form of cardiac event up to 3.5 years out. And those that even had the transiently positive troponins had a 37% risk of having a cumulative cardiac event. So you can see here, this really helps sort of stratify maybe which individuals would be best suited for sort of collaborative follow-up with cardiology. Danielle Cardinal group then went on to sort of question, in anthracycline-induced cardiomyopathy, is there any clinical relevance in response to pharmacologic treatment? And they took a total of 201 patients that had an LVEF less than 45% after anthracycline exposure, and gave them enalapril and Coreg and up-titrated these therapies relatively quickly. And they looked at cumulative cardiac events, sudden cardiac death, pulmonary edema, admission for heart failure, and arrhythmia. And they sort of divided the group into three groups. You had responders that had an EF greater than 50% after initiation of enalapril and Coreg. You had partial responders that had an increase in ejection fraction of 10 points, but their EF still remained below 50. And then you have the non-responders that their EF did not even improve at 10 points, and it still remained below 50%. And the interesting thing about this study is that obviously responders tended to have less cumulative cardiac events, but the time till initiation of treatment really predicted which individuals would be responders. So the critical thing to sort of take home from this point is that if these individuals were diagnosed within 1 to 2 months and started on enalapril or Coreg, their chance of becoming a responder and recovering was 64%, versus those that were found at 2 to 4 months had a 28%. And you can see sort of a drastic fall off after 4 to 6 months. Your chance of being a responder fell dramatically. So I think it's critical to identify LV dysfunction early and get patients started on appropriate treatment. So our current monitoring algorithm for cardiotoxicity with anthracycline-based chemotherapy, like I said, there are no sort of consensus guidelines on how we should do this, but we look at centers such as MD Anderson and Vanderbilt and other centers around the country that have sort of cardio-oncology collaboration and protocols in place. And what we tend to do is prior to any kind of anthracycline, prior to cycle 1, we check an EKG, troponin, and BNP, and we usually have an echo with myocardial strain as well to look for any kind of early cardiac dysfunction, and repeat the troponin and BNP prior to each cycle. And if within normal limits, we go ahead and proceed. If the troponin or BNP is abnormal, we then we'll check with an echo and consider initiation of beta blockers and ACE inhibitors. Continue chemo as long as the EF is above 50%. So anytime it falls below 50%, we usually really ramp up the beta blocker and ACE inhibitor, and we keep an echo in 3 to 4 weeks. And anytime it falls below 40%, that's really when we talk about with the oncologist what's sort of the risk-benefit ratio of continuing. But we continue this for every cycle. It's just to help enhance our monitoring strategy. So we may say, well, you've shown me all this evidence that beta blockers, statins, and ACE inhibitors and ARBs could be beneficial. Why don't we just give it to all oncology patients? And I say one size does not fit all, especially in oncology patients. These individuals are going through chemotherapy with a lot of side effects of fatigue and muscle aches and pains. And so if you start adding on a bunch of medications, could potentially compound their side effects. And I think we need the data. Internal medicine is a very evidence-based driven field, and so we really need the data. I think cardiology has sort of been seen other clinical studies such as POISE, where we thought perioperative beta blockers were good for everybody. But really, when we started ramping up beta blockers and everyone for a perioperative strategy, we saw it caused more harm than good. So we really need larger trials in cardio-oncology to say that we should just initiate these medications up front without sort of selecting which patients will benefit the most. So let's switch gears and let's get away from breast cancer. Let's talk about some other things. We have a 52-year-old male with a history of coronary disease, had a stent to his LAD 2 years ago for non-stenting. He was diagnosed with advanced gastrointestinal stromal tumor and treated with sunitinib. His pre-chemo echo showed he had a baseline EF of 58%, no wall motion abnormalities. He did have a little bit of left ventricular hypertrophy. And 9 months later, he comes in complaining of paroxysmal nocturnal dyspnea, lower extremity edema, and repeat echo shows he has an EF of 42% and global hypokinesis. So let's talk about sunitinib briefly. Sunitinib is a multi-targeted tyrosine kinase inhibitor. It was approved by the FDA for treatments of advanced renal cell carcinoma as well as just tumors. Its targets include VEGF 1 through 3, platelet-derived growth factors, c-KIT, and other receptors. In 2007, sunitinib was registered in more than 120 active clinical trials. And after the completion of both phase 1 and phase 2, there was a little bit of a signal that was emerging that was increased cardiotoxicity. So let's talk about that a little bit. So Chewing did a retrospective review of 75 patients that had imatinib-resistant metastatic GIST tumors. And they examined composite cardiovascular endpoints, including heart failure, MI, or cardiac death. And they saw that 8 of the 75 patients, 11%, had some kind of cardiovascular event. Additionally, they examined sunitinib effects on LV function. They saw 6 of the 8 patients actually develop heart failure. And so when they looked at the actual waterfall plot of their change in LV function during sunitinib treatment, they saw significant effects of cardiac dysfunction by sunitinib. 28% had an absolute decline in LVF of 10%, 19% had an absolute decline in EF of 15%, 47% developed significant hypertension defined as greater than 150 over 100. And the only good thing that they did find is that when heart failure was diagnosed or LV dysfunction was determined, that the sunitinib-treated individuals generally responded to initiation of heart failure therapy. So again, it looked like this was a reversible process. So they looked at a multivariable analysis to define who's at greatest risk. And so with this multivariable analysis, they saw that those that had coronary disease had a significant independent predictor of cardiovascular events. Their odd ratio increased to almost 40. So if you're treating sunitinib patients and they have underlying cardiovascular coronary disease, you kind of need to think about screening or monitoring those individuals even closer. So Chu and others also looked at what happens directly to the cardiac myocytes with sunitinib exposure, and this was actually in a mouse model. And you can see there's significant injury to the mitochondria in comparison to controls, as well as development of sort of whorly crises in the mitochondria. And when they did cytochrome staining to look at what's happening to the mitochondria, in the sunitinib treated, you can see a significant number of increased release of cytochrome C, so just suggesting that sunitinib causes direct cardiotoxicity, probably by inciting mitochondrial injury and induces myocyte apoptosis. So these authors concluded that LV dysfunction was likely caused by the direct cardiomyocyte toxicity, which was likely exacerbated by the high incidence of hypertension. In general, they suggested that we should have close monitoring of tyrosine kinase inhibitors, and that further studies are actually needed to define cardioprotective strategies in tyrosine kinase inhibitors to help prevent any further cardiovascular events, as well as to prevent any interruptions to therapy. Let's go to our next case. So Mr. Henry, he's a 57-year-old male with a history of diabetes, hyperlipidemia, former tobacco use. He had fatigue and epigastric pain. He actually underwent a left heart cath that revealed a 50% mid-LAD lesion and an EF of 55%. 1 month later, he was diagnosed with metastatic hepatocellular carcinoma. He was started on oral sorafenib, gemcitabine, a platinum agent. He was admitted several times for chest and back pain, and it was all found to have negative cardiac workup with negative EKGs and troponins. And it was attributed that his pain was due to his metastatic disease. He continued on oral sorafenib for 11 months and then developed shortness of breath, indigestion, dizziness, sort of left arm pain. And he presented with this EKG, and you can see this is a good classic EKG showing significant ST elevation in the inferior leads as well as in the anterior leads. And he was treated with aspirin, heparin, and low-dose dopamine. He had some mild hypotension. And when they went on for a left heart cath, he had significant progression in disease in the LAD as well in the left circumflex, and you can also see a disease in the right coronary artery. Interesting thing is that when they infused intracoronary nitroglycerin, that these stenosis improved, and this sort of confirmed the fact that this individual was actually having vasospasm. And so sorafenib is another tyrosine kinase inhibitor. It's a targeted tyrosine kinase inhibitor. It inhibits VEGF, platelet-derived growth factor, c-KIT, BRAF, and RAF1. It was FDA approved for renal cell carcinoma, GIST, and unresectable hepatocellular carcinoma. Previous clinical trials and reports demonstrated that the cardiovascular events were actually rare. But since then, there have been several case reports which have shown there's been increased evidence of vasospasm with use of sorafenib. So what is the mechanism? Well, it's thought that sorafenib probably interacts with the endothelium and causes endothelial dysfunction, especially it's exacerbated in the presence of comorbid diseases, like our case patients that had non-obstructive coronary disease and had diabetes and hyperlipidemia. And that in general, if you're having a VEGF inhibitor, you're reducing vasodilator mediators such as nitric oxide and prostacyclins, and increasing vasoconstrictors such as endothelin. So what about adult survivors and screening? So luckily we have emerged a number of new agents, and our life expectancy and the number of survivors is drastically increasing. What are we doing to screen our survivors and make sure they don't develop further complications? And if you think about it, after recurrent malignancy, cardiovascular disease is the #1 cause of death. So, and these adult survivors of cancer have significant comorbidities. In comparison to age-matched controls, cancer survivors have a very high incidence of cardiovascular disease, hypertension, obesity, diabetes, and a third of these individuals are disabled. So we have significant room for improvement in helping our cancer survivors. So our guidelines for adult survivors, unfortunately there are no consensus guidelines out there on how we should be screening and monitoring these cancer survivors. We do have some proposed screening recommendations from the MD Anderson group, where they really recommend in our stage A patients that have received anthracycline, trastuzumab, or any other tyrosine kinase inhibitor. We sort of stratify them by stages of heart failure, and if you're still in stage A, they recommend at least every 12 months, considering a BNP and possibly an echo. There was recently, just this past October, the European Society of Medical Oncology that came out with some clinical practice guidelines that then stratified people. If they had a positive troponin during their treatment, they suggested that we initiate an enalapril, and then for sort of follow-up after their chemotherapy actually ended, getting an echo at 3, 6, and 9 months, and every 12 months after for at least 5 years. So in this algorithm, they suggested if you had positive troponin to be even more vigilant. If you had troponins that were negative, you probably could then just go to screening every 12 months. And if you did not have troponins during your evaluation, they suggested you become a little more vigilant at the end of chemo and have an echo at 3, 6, and 9 months, and then yearly after that. So again, we're sort of developing these guidelines on how we should be monitoring these individuals. So I think in the next few years we'll have sort of consensus guidelines, both from the cardiology and oncology societies in the U.S. So this is a consult from your internal medicine colleague who practices med-peds. Jim is your good friend and wants to know how often you recommend cardiac screening for childhood survivors of cancer. Jim states he's following a 30-year-old male with history of ALL, diagnosed at the age of 8, with previous anthracycline exposure of 300 milligrams per meter squared. And he asks you, are there any standard guidelines for cardiac screenings for childhood survivors? And actually, yes, there are. And in general, the Children's Oncology group is way ahead of adult survivorship programs. They have a very well-defined survivorship guidelines. And they go through actually every chemotherapy agent and have recommendations for various screening. And for this particular individual, if you ever have any questions, you can go to the website. But for this particular individual where they had anthracycline, he was diagnosed at the age of 8. He had greater than 300 milligrams per meter squared. So the recommendation is that this person have a cardiac function performed at least every year. So our take-home points for today is that chemotherapy-induced cardiovascular disease is not rare. Cancer patients are living longer, and the cardiac status should be monitored for late-onset complications. There's growing evidence to show that biomarkers such as troponin can be used for screening and for prognosis in these individuals. ACE inhibitors, beta blockers, and statins seem to be emerging as first-line treatments for cardiac dysfunction, and may even have some benefits in preventing chemotherapy-induced heart failure, as well as improving cancer outcomes. Our current gaps in cardio-oncology, probably the biggest glaring thing is the lack of consensus definitions of cardiotoxicity. We need improved risk stratification for cancer patients prior to undergoing treatment. We need formalized guidelines for active monitoring during chemotherapy and for adult survivors. And we need larger clinical trials to understand the long-term effects of chemotherapy and cardioprotective strategies. And it's all about building collaborations. There are 2 large cardio-oncology societies. And U of L is all about building strong courage and national prominence. And I think we're well poised to really make an impact for the people of Kentucky and the Ohio River Valley as we develop our cardio-oncology program here. And we're all on the same team, and I want to give special thanks to the women who participate in my cancer research. Obviously, the great collaborators at Vanderbilt, as well as the Brown Cancer Center. My mentors, Doug Sawyer and Dan Linehan. Fellows, Sam Abdullah, the president, working with Mirman Bahata, and then my research coordinators. And I want to remind you, tomorrow is February 1st. That marks Go Red for Women Month, so thank you for your attention.
Thank you, Carrie. I had one question for you. You showed us about the complexity of how these cancer drugs may affect the heart and how multiple pathways can be affected. You also showed us that some of the congestive heart failure drugs that we use can be helpful,
Right.
but can also be helpful in the treatment of cancer.
Correct.
I have to assume that there are some of these agents that could also counter the anti-cancer effects of these drugs. So you may improve heart function or prevent heart progression while at the same time inhibit the effects of the anti-cancer agent. Is there data for that?
There's not any strong data yet to show that these medications inhibit the anti-tumor capacity, but that is a concern, and that's why you probably do not want to throw statins and beta blockers, ACEs and ARBs at everyone because of that potential. But I would say most individuals who are designing these prospective studies looking at statins and ACE inhibitors and ARBs in large randomized groups are looking to make sure they're not causing the progression of their oncology endpoints. So we're looking for oncology endpoints too to make sure we're not exacerbating things.
Questions? Craig.
So you showed a lot of data about obesity and risk factors, especially early you talked about drug transporters. So has anybody actually looked at the liver kind of honed down a little bit further? So with obesity, you have fatty liver and NASH, and there's documented abnormalities with oxidative stress disorders with increasing disease. So could that be affecting the cardiotoxicity?
It certainly could be, and that's something that in this new grant we're really proposing to look at too, specifically for the pharmacology of anthracyclines, especially in the setting of obesity. So you're exactly right on.
Roberto, you had a question, and then Melissa.
So, as you said, one of the keys is to identify patients at risk,
Right.
Which is important for you to the genetic makeup. So, are there any studies, like GWAS studies or studies of SNPs, trying to figure out which SNPs or which genetic makeups predispose to this? It seems like a no-brainer.
Right. Yeah, so as far as I know, there are no large GWAS studies. There have been several studies looking at various SNPs, and the SNPs that seem to be highest benefit of identifying those at risk are actually the ones that are involved in the drug transport, the MDR polymorphisms of the efflux protein. So there have been studies looking at that, and then various enzymes that are responsible for the reduction of doxorubicin. But I definitely think that's going to be a growing area of interest, not only for anthracycline, but for all the other newer agents that are coming down the pipeline that we're using.
Are there any, do you have any knowledge of what the systemic effects of early stage cancer are on the heart? The reason that I ask that is because, survivorship and the study of survivorship issues is becoming very big.
Yeah, so there's not been much as far as like diastolic dysfunction or anything else, and then looking at as a predictor of cardiotoxicity. But it has been shown in multiple studies that early endothelial dysfunction is a poor prognostic indicator. But again, endothelial dysfunction is kind of just a marker of underlying risk factors of obesity and metabolic syndrome and so forth. But definitely, I mean, when you give some of these medications, you see total obliteration of the endothelial function, even in people that have normal. So definitely that's why we're seeing some of the chemobrain and the other effects vascularly. So definitely something we need to continue to monitor.
Questions? Yes.
When you talked about the screening guidelines, you talked about stage, that already included an echocardiogram. There's obviously a great population that had chemo prior to this type of recommendation. Is part of your future studies going to recruit, people 5-10 years out and do echoes and then come up with guidelines for them?
I think there's a huge room in the survivorship population to better understand how we should be continuing to monitor and continue to treat these individuals. And I would say as all the research in survivorship continues to grow, that'll be an area of active growth as well.
I assume there's very little data in men with breast cancer. Is there enough data to determine that there are differences in the behavior of men and women with respect to these drugs?
Yeah, I've not really seen any data to show there's any difference probably because of such small numbers. But something to be looked at. I know Dr. Jane actually did a study looking at males with breast cancer from a VA population. But something that definitely needs to be teased out with the VA, with the electronic medical record, probably be something very worthwhile going back and looking at.
Well, thank you so much. I want to remind the faculty that many of you, I think everybody, received an email indicating that tonight is our annual gathering where faculty meets with some of the student candidates who are interested in participating as a part of our residency program. We have seen an increase in the candidates from U of L in the past few years, and it's a great opportunity for you to meet the candidates, for them to meet you, and to attract them to our place. Thank you so much, and Carrie, thank you so much. That was very good.